Hello and welcome, everyone. Thank you so much for joining us for session 3 of our recovery-oriented systems of care webinar series. We'll let folks get settled in and we will be starting momentarily. All right, thank you again for joining us for session 3 of our recovery-oriented systems of care webinar series. Today's training is brought to you by ATTC and SAMHSA. The Great Lakes ATTC and PTTC are funded by SAMHSA under the following cooperative agreements. The views expressed in this webinar are the views of the speaker and do not reflect the official position of DHHS or SAMHSA. The ATTC network uses affirming language to promote the promises of recovery by advancing evidence-based and culturally informed practices. We do have a few housekeeping items for you before we begin. If you are having any technical issues, please individually message me, Alyssa Koala, in the chat section, and I'd be happy to assist you. Any questions for the speakers, please use the Q&A section of your toolbar, not the chat. Please use the Q&A section. We will be having a little panel discussion at the end, and we would love to answer any of your questions. If captions or the live transcript would be helpful, please locate that option using your Zoom toolbar. At the end of today's presentation, you will be redirected to a very short survey. We'd greatly appreciate that if you could fill that out. And as long as you attended today's session in full, certificates of attendance will be sent out via email to all who attended today. If you would like to stay connected with the Great Lakes ATTC, follow us on Facebook, check out our LinkedIn. We have a YouTube channel and we have our podcast channel on Spotify. And I'm super honored and excited to hand this over to our presenters, Dr. Flaherty, Precia Stuby, and Zach Thomas. Thank you so much for being here, guys.
Anyway, here we are. Good. I think you can hear me now. Good morning or good afternoon. I'm Mike Flaherty, and just such a pleasure to have you with us today as we go through this third webinar in our series of how to use ROSC to address America's mental health and substance use challenges today. And today in the third webinar, we're going to feature some culmination of the work that we've done with some of the experts bringing to you just that very information. So welcome and thank you for being here. Zach, first PowerPoint, please. Okay, I can't see the PowerPoint, but I can talk to it. There it is. Thank you, Zach. And the most important thing on this slide is the thought of empowering communities to address America's mental health and substance use needs. And the reason for this we'll talk about, but in our opening webinar, I tried to make the case that the path we're on and is not necessarily going to get us where we need to go in resolving this challenge that our country faces in both mental health and substance use. And my email, should you have further questions that you would like to address to me. Next PowerPoint. Thanks, Zach. This is what I hope to cover in my brief presentation today in the third webinar. A brief overview of the first two webinars, discuss for you or show you some of the roots of where a ROS came from, and using recovery itself as a unifying construct for everything we do, that it in turn then empowers the community to find its own solutions and to have solutions that come up from the community, unique to the challenges of each community. We'll talk about the recovery science repositories that exist today, where you can go to get more information or help. Should you have questions, we'll go into a more detailed overview of the evaluation of ROSC over the past years that has been done and by Brandeis University, and the pillars that are necessary for uh, you know, accomplishing a ROSC. And of course, we'll mention overdose and passing, as well as harm reduction. But we'll also be talking about hearing from Brandeis University and their experts that they devoted themselves to the evaluation of ROSC. And lastly, I'll just review very briefly how to begin or build a ROSC in your very own community. Next slide, please, Zach. First two webinars, we opened up the first one just to give you basic terms, why recovery, what recovery is, the importance of defining recovery in your community, what principles are of recovery, what the objectives of recovery are, how to educate a community, bringing it together, putting your leadership and your community at the same table with providers and researchers so that you had a joint community up initiative to address the overpowering at times challenges of both mental health and substance use that our country faces. And the second webinar then addressed one of the largest challenges in doing a ROSC to our country and to our communities. That is, how do you find the workers? And we opened up in that particular webinar examples of different agencies that used it to expand their workforce, and how the role of peers and peer development and recruitment, and the role of families as peers, and the other members of communities that can be found to come into the community and really add strength. We should be able to use our own communities, including, veterans, including people who have gone through experiences themselves, even perhaps people from incarcerated histories that can now come back into the workforce in a positive way and add to our strength. So it's a healing of the country to expand our workforce. Next slide, please. And the roots of recovery go way back. This is a painting, a sketch that was done in 1952 at the origins of actually AA. The picture, you may have seen it, called The White Light, or the light experience of Bill Wilson, the origin, originator of Alcoholics Anonymous. And while ROSC is not any one approach, so much of recovery itself was. And in this particular picture, Bill W. was sitting with two gentlemen. Some say two people from the fellowship itself, that is, was just forming. Others say it was Dr. Silkworth, or Dr. Bob Wilson, who was co-founder of AA. And it looks like a copy of the Bible in their hand, although some people say it's a copy of the Big Book. And the picture portrays the very moment when this individual, was Bill W. or whomever, and it could be any of us, have come to see that light and give up the uses and the dominance of substances or mental health issues in our life, and turned ourselves over to, in this case, a spiritus of, in not particular religion, but a spiritus of belief that you could do it yourselves. And in this moment, in this transition, is when the roots of recovery begin for all of us. And with ROSC, we said to ourselves, we should look at this and learn what is inherent in that experience, so we build on it. Next slide, please. This, I will contest, is one of the earliest ROSCs. The roots of ROSC. This is going back now to 1892, so even before Bill W. in this community in Kansas, or I'm sorry, Illinois, Dwight, Illinois, or a group of gentlemen, as you can see. And I'm sorry about the sexist presentation of the photo, but it was just the way it was then. And they gathered together and said, we are going to ban drinking and alcohol in our community, that the law must recognize the leading fact that it's medical care, not penal treatment, that will reform us. And this group, the origin of what was known as the Keeley Society, had at one time as many as 30,000 members, and they traveled on trains and spoke from the back of cabooses and passenger cars to communities, trying to get them to unite and form what they could through sobriety, in many cases complete abstinence. They were trying their best to bring their community solution to the problems that at then time was alcohol itself. So I would say this could be considered the origin of the first community up approach for ROSC. Next. So recovery itself has to be defined. And the most important part of that is as a unifying construct. And here I want to refer to a colleague, a dear friend, Bill White himself, who has often referred to unifying construct in his writings. But why do we do what we do? And when you go out to your communities, or when you come to work in the day, or when you challenge yourself with why you get up in the morning, just remember that recovery is, what it's about. It's not about just getting treatment as usual, but it's about going beyond that to the measures of recovery: a better home, a better life, a better, health care, positivity, your meaning in life, etc. And those measures do exist, and we have them. The recovery today is defined by SAMHSA as a process through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential in four major dimensions of their life: health, home, purpose, and community. And if you notice here, this is an evolved term. Many other terms have come at the origin of the definition of recovery. This is where we are today, and will probably evolve again in time with evolution of our society. Next slide, please. Community empowered solutions is what recovery offers, bringing the community to solution. The importance here is recognizing that the power of the substances and even mental illness are overwhelming to the individual, to the family, and many times to the community. But if the community doesn't delegate or relegate that responsibility to address it to systems alone, it can come together and address its unique concerns and build on what that particular community needs and to overcome this problem. And that's what you're seeing examples of in these three webinars, and we'll get again in this particular webinar today in the panel that concludes. The focus, though, of a recovery-oriented system of care is, again, to unite through the overarching belief that recovery is why we do what we do. That does not mean abstinence, for those that may be wondering it. It could mean abstinence and should mean abstinence if it's possible, but if not, there are other ways to be in recovery even without the abstinence in the immediate moment. Anyways, it is a recovery-oriented system of care is to create a coordinated system within a community and a structure for community and provider-led accountable services and resources over a continuum of care. In other words, you're seeing the illness over a continuum, and that illness must be addressed through education of the community, through prevention of the illness. One of the largest components of a ROSC is prevention, and we can talk about that in the questions. Intervention, a brief screening, a treatment episode or episodes, and then finally moving into some form of the recovery for the individual over the number of measures that there are for recovery. So we're moving the person off of just getting treatment and being put back in the community or the street corner, and moving them back over to a life of improved health, wellness, and population health. Next slide, please. What is a ROSC? Definition today by SAMHSA is a recovery-oriented system of care, coordinating a network of community services. So they work together. The Department of Health with harm reduction works together with the mental health and substance use for treatment, which works together with the jails to help people that end up in the jail because of the inability to get an intervention earlier, which works to the schools, which helps do prevention early in the schools, et cetera, particularly from persons in the community that are perhaps highest risk. And you'll hear more about that as we go along today with the efforts of Hancock County to bring in all voices, particularly those that are in a minority or lesser empowered position, so that they can be healed with recovery. Taking care of the least, you do the most for all. It's a bottom-up solution again. And it's built upon the strengths and resilience of individuals, families, and the community. You get your recovery capital scores, you achieve recovery, and you measure improved health and wellness and the quality of life for those at risk in the community. And this would be, another definition for population health itself. Next slide, please. This is a repository of where to go. Now, you have many people. You've got all of the fellowships today in America. There are many, many fellowships, different conditions, different supports. But in addition to these grassroots fellowships, there are peers. I was talking with a program yesterday where a barbershop the barber was using his abilities to reach people to get them to get help, and he didn't realize that if he connected with a peer, he could just even do more by having the peer meet the people who comes to the barbershop or the hairstyling salon. And it's a concept promoted by Community Care Behavioral Health in Western Pennsylvania, actually all across Pennsylvania, in their Medicaid managed care company. And it's a wonderful program that is linking people where they are at to getting the help they need. The major national repositories are before you. SAMHSA, of course, has a repository of all of the articles, all of the materials that you would need to understand what a ROSC is, how to build it, what the principles and objectives are, the effectiveness of ROSC, etc. I would put them as the premier repository, mostly because of the national acceptance of the science that they do. You don't get to SAMHSA's website without being cleared. National Institute on Drug Abuse is a similar one, where you have tons of research and biological understandings of what is a disease, what is a disease of alcoholism or a drug addiction or not mental illness, once there, NIMH would be that, but you have these repositories where you can go and educate your children earlier, show them the effects of alcohol or substances on the brain, marijuana on the brain. It's there. The Recovery Research Institute at Harvard, led by Dr. John Kelly, is another resource with all of the articles, no, not all, but most of the ones. There are international research now studying these approaches and these methods and their outcomes, and you can get to all of that just through going to that particular website. William White, his repository at the Chestnut Health System, where I think some of the finest papers written by those mostly who've experienced the illness are stored. But if you have a question, if you want to know something about children and substances or age of onset or number of episodes of care before you can have a chance for a 50% chance of recovery, these two, the Recovery Institute and William White's papers, are probably the best. And of course, there's the vehicle that we're on at the moment, the Great Lakes ATTC, which is designated by SAMHSA as a recovery-centered ATTC for knowledge and passing on dissemination of that knowledge. And they have a whole network around them that I would love to have the time to talk to you about, which is the ATTC network itself, which is just unbelievable in terms of accessing resources should you need them. Next slide, please. So how to begin a ROSC, if in one sentence or very quickly today. And I tried to put it together and boil it down to a Reader's Digest version, and then I boiled it down one more time. But these are the essential elements in your community. And if you feel the passion or the idea to do a ROSC, investigate your repositories, your information, your science, bring it to your leaders, and identify who your leaders are in your community and the providers. They hold responsibility, but at the moment they hold responsibility to their funders. Well, we want to make sure that they also hold responsibility to the community. So identify your leaders, bring them together, and put the science into their hands, working together to identify the real priorities in the community. Some things may already be resolved and don't need to be addressed. Agree on your vision, have that overarching construct that it's not just getting people into treatment. It's not just getting new services to the community. It's not just having a complete continuum of care, but it's deeper into the human aspects of what principles are, and respect given to individuals and families, and the need to heal and accept who we are together. It's very much a gathering together of a community. Assess for gaps in your service and continue system. In other words, come in. This is how Hancock County began. They looked at the gaps in their service system. What didn't they have? Did they have withdrawal management? Did they have housing? Did they have programs for veterans? Did they have programs for pregnant women? And they pulled it all together at the same time of organizing this unifying construct. And that's what you're getting in these 3 webinars today. Embedded all in the philosophy of recovery and everything. So everybody is looking for not just an intervention, not just treatment, but an overarching sense of the individual's feeling that they have returned to their freedom, to their choices, and to their best aspects of what they can be in their life, a recovery. And that's exactly what you want to have, not just you're done with 8 episodes, goodbye. Measure and continually report back to your community and your providers, on your outcomes. It's a continuous accountability, continual self-improvement. It's a starting point with an improvement, a starting point, an improvement, a setback. And don't forget that what you're getting in these 3 webinars is a result of also going through a pandemic and an epidemic, an opiate epidemic and a COVID pandemic. Next slide, please. Evaluation. Well, this is where I'm going to bring into the evaluation component and introduce you to our speaker on that topic. Before I do, I wanted to say there are 3 pillars of critical evaluation of a ROSC, of a system of care. One, does that system improve access to its people, to its clients, to its families? Does it give them a satisfactory retention? Do they stay in treatment long enough to have an adequate dose of care? And there are all kinds of scientific evidence behind that, such as NIDA's 90-day continuum of care is minimal for anybody with a substance use diagnosis. How many are getting 90 days in your community? Or, are you keeping people with the right medications and adjusting them appropriately, or are they falling out because they aren't getting, et cetera, et cetera. And the last one is, and this is the most complicated of the 3 pillars of evaluation, improve your outcomes. These are where you cut your recovery measures and you look at what your individual's doing in your recovery measures, and you say to yourself, are they abstinent? That would be wonderful. Are they reducing any illegal activities? Are they finding a better home to live in, a better family life? Work or meaning in their life is a huge one in this particular area, more than any other medical, physical illness. So these are the 3 critical pillars, that overarching pillars to the evaluation of a ROSC in your community. You provide accountability and progress. You expand your workforce by doing so because you're addressing those needs. Getting people, blankets, or getting people, food, if they're, which are critical today. Food worries or housing. Are you getting into that? You need new workers, and empower local solutions. And with that, I'm going to now introduce you to one of our evaluators, Dr. Joanna Taylor. Dr. Taylor comes from Brandeis University, where she has for the past 2 years been our evaluator at the core root of our ROSCs in Hancock County, along with Dr. Mei Lee Kim, who was unfortunately not able to be with us today, visiting in Korea. However, you will get some excellent information from our sort of grassroots evaluator, Dr. Taylor, who has a great passion for this work and working with youth and children. So with that, I'll turn it over to Joanna.
Thank you so much, Dr. Flaherty. Thank you all for being here today. I'm excited to share some of this information with you about what's happening in Hancock County and the role that evaluation plays in understanding a ROSC. I do want to shout out Mei Lee Kim, who is my mentor and supervisor in this work. She's been working in Hancock County for 6 or 7 years now, and has over 20 years of experience looking at behavioral health projects across the country. So I'm very lucky to work with her and learn from her, and I'm excited to share some of our work with you all. Zach, yes. So I'm going to talk a little bit about the role of evaluation, the role of evaluators, and some of the outcomes findings that we've found across different projects that are occurring in Hancock County right now. Okay, so just to start off, you know, the CDC lays out what evaluation is, and they discuss about the sort of overall goal of evaluation is to collect, analyze, and use data to examine the effectiveness of programs and to contribute to program improvement. So it's a process, and there's no single endpoint to any of it. And certainly the way that we've approached the work in Hancock County is to continuously go back to stakeholders in the community, to different projects, and to try to work across those to ensure that lessons are spread from one place to the next, and that we're working all together to really enhance the entire community and not just one individual project at a time. Zach. So I wanted to talk a little bit about different types of evaluation, because different programs and different projects are going to be at different stages of needing different kinds of evaluation. So a formative evaluation is when you are sort of getting started. You're thinking about, what do we even need to implement right now? What do we need to do within an initiative that currently exists to improve it or make it better over time? A process evaluation, once you're sort of in the midst of implementation, is going to let you tweak as you go, right? Little tweaks, seeing where things are working, where things are not working, and providing early warnings for needed adjustments. After a project has been going for a while, you can start to get to some outcomes evaluation, and that's what we're going to talk about some in just a minute. Is, you know, is this initiative being effective? Are we meeting the objectives that we've intended to meet? Do we have any unintended consequences, which can either be positive or negative? And what do those tell us about what needs to happen next? An economic evaluation, right? Is this cost effective? Have we driven down the costs of providing these various services? What are the cost trade-offs that we might have? And then an impact evaluation, as things wind down, understanding what worked and what didn't, and what you might take forward into policy change in other places, in funding decisions, in advocacy that you might take into other parts of your work and other arenas. Okay, so what does evaluation take? The role that, or the approach that Brandeis takes and that we take to this work in Hancock County is first and foremost to be very much on the ground and listening. So engaging stakeholders, program participants, providers, organizational leaders, policymakers, looking at the media and what's being put out in local newspapers, et cetera. So really understanding the community context of where an initiative might take place. To really work with staff to understand what they think any initiative is going to do and how they think it's going to fit into the larger context of what's happening in the community for ROSC. And then to build their understanding of the goals of an initiative and their capacity to meet those goals, which really empowers them to spread this word about what ROSC is and what it could be, and where we're trying to go with it, not just within, you know, professionals, but also out to program participants. Evaluation is very much about data. So identifying data sources, whether it's something that's being collected through a formal electronic health record system, or again, through the local community paper, right? What's being put out there in terms of the sort of discourse around recovery. Ensuring data completeness and accuracy, right? We get a bunch of data from a variety of sources. We have to figure out how those can be merged and combined and what they can tell us, whether there are holes in the data that we have, and what that, how that affects the kinds of questions that we can ask. And then to provide that data back so that folks who are community members, who are decision makers within the community can say, oh, this is the next thing that we need to do with it. So it's a constant feedback loop through all of that. And with that data and information about where there are holes, to say, oh, the next thing that we need is this kind of grant or this kind of initiative, and writing the grant proposals to help with that, monitoring those budgets and the resources that are available, and then also just showing up to be in the community as much as possible. And it's a really exciting, very interactive way to engage in evaluation work. So an evaluator's role: technical skills, content knowledge, also interpersonal skills and transparency, right? So our job is not just to rubber stamp an initiative, right? So the little cartoon, we hired you, your job is to report what we say. Well, yeah, you hired me, but as an evaluator. So my job isn't to just tell you what's great about you, it's also to tell you where are the warts and what do we need to keep working on. And that does take a lot of finesse. It takes relationship building, and it takes time to really understand the community context so that you know where to push, what the things are that really could happen, and so that you really are listening and feel like you're a part of it and not just totally on the outside. So this is a timeline of the Hancock County ROSC and our role from Brandeis evaluating different initiatives within the county. So back in 2018, there was the first Hancock County System of Care grant, which was funded by SAMHSA, was awarded. And there was a lot of work in 2018, which, 6 years ago now, to collaborate across systems to streamline early identification of youth who might benefit from it, referrals, treatment, follow-ups. Through that first grant, work to coordinate policies and procedures, not just within the behavioral health system, but across youth serving systems, and across recovery-oriented systems. Obviously in 2020, the pandemic hit. And so a lot of the things that, everybody thought was the next step turned out not to be the next step, because everybody had to pivot to deal with what the needs were at that moment. And ever since then, right, training and retraining leadership and workforce and the entire community on what are the evidence-based practices, what are the policies, what are the procedures, how do we continue to build our system, even in this moment when everything that we thought we knew about how we all operated shifted quite a bit. And so there's been a lot of leveraging of pandemic-driven resources, right, like telehealth, to expand school-based services, to expand youth services, to expand recovery-oriented services generally, in terms of the criminal justice connected population, in terms of folks who are dealing with substance use and other struggles, to really explore what are the things that we can put out there that are going to be initiatives that interlock to provide that full recovery-oriented system across the community. So this graphic gives you a sense of just how many different initiatives there are right now. Brandeis does not evaluate all of them, but because we evaluate a lot of them, that we have an amazing opportunity to help connect all of these different systems. So SOC stands for System of Care, which is a youth-oriented project. CCBHC is a national initiative to create certified community behavioral health centers, which are providing low barrier access to behavioral health services, including recovery support services across the nation, and Hancock County is home to one of those. A host of harm reduction services. There's been so much work, even just in the last 2 years that I have been working on these projects. In terms of LEAD, the law enforcement assisted diversion or deflection, the quick response team, QRT, Project Home, which is coming. It's going to be a low barrier shelter that's going to allow unhoused individuals in Hancock County to have more access to both housing and recovery support services. The county now has a mobile health clinic. And then in addition to all of that, we have recovery support services through Focus, which is our recovery community. And you'll hear from Brooke Nissen, the head of that, in a bit. The lead program, again, Christina is going to speak a little bit later. And then in addition, coming out of the pandemic, the county decided that it really needed a crisis stabilization service. And so that's the Steady Path. So all of these things have interconnected to really provide, again, that linked, networked sense of how do we get to a recovery orientation, not just within a single program, but across a whole community. So I want to talk a little bit here about some things that are happening within some of these initiatives that I just mentioned. So the Steady Path is the Crisis Stabilization Center, and it opened its doors in January of 2022. And so by the end of 2023, I'm going to say give you some numbers next, but this was a quote from a stakeholder. The Steady Path has become the highest level of care available from the community mental health system. So there's something between the emergency room and going home, between jail and going home, between inpatient and going home. And before we get into those places to try to stabilize and keep people safe. So really focusing on what is the bridge between those true crisis services, the acuity, and having somebody fall off a cliff. Can we provide a bridge for them? So that's the goal for the Steady Path. Next, Zach. So at the end of 18 months of services, there were 167 enrollments with referrals from mental health, housing, and criminal justice sectors. 90% of folks came in and were provided with or were helped to stabilize their psychotropic medication so that they were more able to manage their own daily lives. 62% of folks were discharged with goals met, and an additional 9% were it was discovered that they really needed that higher level of care. So it was between home and acuity, there was a bridge there to really assess them and to be able to say, yep, actually, you really do need that next level of care. And the Steady Path began accepting admissions from neighboring counties, really expanding the reach, right? Hancock County is now supporting not just within its own borders, but also across more of Northwest Ohio. All right, so the System of Care Grant, again, is our youth-focused initiative, and it's really focused on multi-system involved youth. So youth who are in foster care, who might have juvenile justice cases open, who are struggling in school. And so we had one round of that grant from 2018 to 2022, and then we got a second round of the grant in 2022. So we actually have 6 years now of data from the System of Care Grant. And again, at the end of the first round of the grant in 2022, and we did a series of interviews, one stakeholder said, I would say children's services, juvenile court, behavioral health system work together sometimes, but predominantly we're pretty siloed. Early on, we did a couple of case studies where we brought all those partners together and reviewed family cases. And that began an opportunity for agencies to understand how each other function, why they function that way, and begin problem solving together versus separately. So that was one round of what we called a family case review that was done before the pandemic. It happened in late 2019. And just recently, last March, we did another round. And again, really having so many different systems come together and focus in on a couple of cases and think about what worked here, what didn't work here, what kinds of communication do we need to improve? All of those questions are continuously driving improvements across those youth serving agencies in Hancock County. And we're really looking forward to being able to do those again in a couple of years to keep asking those questions and keep driving it forward. So a couple of metrics, the SOC program is funded by SAMHSA, the Substance Abuse and Mental Health Administration, and they changed their questions between the first round of the grant and the second round of the grant. So I don't have specific things to compare for you across the 6 years. In the first round of the grant, over on the left-hand side of the screen, the percent of youth reporting good, very good, or excellent health or mental health. In cohort 1, that first round of the grant, they asked about overall health. And you can see that from baseline to 6 months, youth were reporting better overall health. And then even more impressively, in cohort 2, just in the last 2 years, youth who are really struggling, we have a major youth mental health crisis, as I'm sure many of you know, reporting improvements of almost 20% in their reported overall mental health from baseline to just 6 months in the SOC program. I also wanted to highlight some of the outcomes there in terms of housing. So during the first round of the grant, you can see that between baseline and 6 months, we had huge drops in the number of youth who were reporting homelessness, who reported going to the emergency room for psychiatric or emotional problems, a drop in criminal justice related activity, so being in a correctional facility or having been arrested, and also just decreases in overall use of the hospital for mental health care. So that was really important in SOC1. And SOC2, this is up to the minute data as of just a couple of days ago, so I don't have a slide on it. But what we've noticed in our current round of this SOC grant is that at baseline, about 12% of kids report not living in a private residence, meaning they're living in a group home, or they have spent time again in the hospital, or they've been arrested. And at discharge, usually between 6 and 8 months in the program, we have 100% of youth reporting that they're living in private residences. So we're really making a big difference in terms of how stable youth feel in the county through this program. One other initiative that I just want to highlight for you all is the Leveraging Peer Support Services grant that is housed at the Focus Recovery and Wellness community out in the Hancock County community. And it's focused on supporting people in recovery by providing both individual peer support services, but also group sessions and community engagement. So during its first year of services from September 2022 to September 2023, the peers employed through the LIPS program supported folks in recovery through more than 300 individual contacts, which could be taking folks to the doctor or just sitting down with them and talking about how they're feeling about their recovery today, or helping them get to work. There are all sorts of different ways that those peers are able to walk alongside folks who are in recovery and support them in very individualized ways. Peers also provided more than 78 group sessions, which happened at the Steady Path, right? So another one of those linkages. Also a common, at least a once a month group session happening in the jail, as well as going out and supporting folks in outreach capacities. So being at the mobile health clinic and other places. And really reaching out into the community to build awareness of and support for recovery support services and hosting community events. All right, so 10-year trends, right? ROSC has been happening in Hancock County for a decade now. The seeds of it were planted a full decade ago, so we want to highlight some community metrics that we're seeing. So overdose-related department visits and admissions, you can see that the ER visits due to overdose spiked in 2017 and have been coming down since then. And also that the ER admissions due to overdose have come down quite a bit since 2019. There's been a huge push for harm reduction across the county, and a lot of that has come down to having naloxone available in a wide variety of places. And I know Christina will probably talk more about that when she speaks, but a huge increase in the number of kits distributed in 2022 and 2023. It really took off having nalox boxes in a bunch of different locations throughout the community, many more people trained. And then this number of known reversals, which is such a fascinating number because, as you'll see in a minute, our overdose deaths have come down so much that it must be true that there are more reversals than we know about. But because the naloxone is so widely available, folks who need it are able to access it and use it without having to have anybody know about it. And that's, I think, for all of us in the community, very encouraging in terms of folks being able to keep each other safe. So here are fatalities. You can see on the left-hand side, the 10-year trend, which is up. However, since 2018, you can see that the overall trend is down, and particularly the 2022 to 2023, just major drop. And again, we would associate that with the availability of naloxone, that fatalities by overdose and fatalities by overdose are way down. And we're continuing to work on fatalities by suicide, figuring out what are the right metrics to follow and what are the right levers to pull to help people know that they can be kept safe when they're in crisis. Okay, so jail admission due to drugs and opiates. Again, on the left-hand side, you can see that across a 10-year trend, that's trending up, but that across the last 5 years, we have a substantial decrease from about 550 to under 400 on the sort of trend line down from 2018 to 2023 for overall drug admissions due to drugs, and also that downtrend line on opiates. And these trends are never going to be specifically, all in one line. We're not going to have a regression model that shows us all downhill all the time, but those trend lines across the years are very, very encouraging, and we're hoping to see even more declines when we get the numbers for 2024. And this one isn't related to a specific initiative, but I think really points to the work that's being done across the community. So infants prenatally exposed to drugs was skyrocketing up until 2018. And you can see just on that right-hand side of this graph that the trend line since 2018, again, has been down. And I think that Brooke will be able to talk some about the Mom's Recovery House, but that number really inspired folks to say, what do we need to do? What do we need to change? How do we need to wrap our arms around mothers who are struggling with substance use so that we can support their babies and make sure that our community stays safer over the long term? So just in summary, ROSC-directed initiatives are providing a framework for systems, behavioral health treatment, criminal justice and law enforcement, social services, veteran services, recovery support services, for all of those systems to collaborate and coordinate across education and policy changes and new initiatives. And evaluation metrics are a great pleasure to be able to watch all of these metrics indicate positive change, which improved mental health for children and youth, increased access to treatment, and increased access to harm reduction services. Thank you so much. I'm going to hand it over to Precia, who is the fearless leader of the Hancock County ATTC Board.
Good afternoon, everyone. I noticed we've talked about how many years we've done this and so on, but we haven't talked about where we are, or how many people we're serving. So Hancock County is rural. We call ourselves kind of a micropolitan, our city seat, but we're a rural community in Northwest Ohio of about 76,000 people. And part of what I have been asked to do as a result of all of these webinars and so on and so forth is to sit back over this 10-year period and say, what are the lessons learned as we look backwards. So before I do that, Zach, I'm going to have you go forward. I just wanted to express my gratitude to each of you. I know there are competing things for everyone's time, every moment of every day. I appreciate you being here. More than that, no matter what you're doing in the field, I appreciate it, because one of the things I've learned is that every role, no matter what you're doing, is important. It takes everybody everywhere to help address this issue. And one of the things that we talk about when we talk about a ROSC, and I'm sorry if I'm repeating myself if you were because of being on previous webinars, but when you want to define a ROSC, as Dr. Flaherty keeps saying over and over, that it's a framework, you can apply that framework. Think of it like a frame of a jigsaw puzzle. across whatever boundaries you want. So it could be a ROSC of a county. It could be a ROSC of a city. It could be a ROSC of a neighborhood. It could be a ROSC of a state. It's about knowing the boundary, like the outline of your framework of your puzzle, to kind of know, okay, this is the boundary. Now within that, we're going to build our ROSC. And one of the reason why I have hearts on this is that Ohio's motto is we are the heart of it all. But I'd also like to say, before I get into the lessons learned, is that one of the biggest hearts that has come to our community has been the gift that we've received from the expertise of Dr. Flaherty. And that's one thing that before I go into all the specific lessons learned, I think the idea of leaning into someone who has some expertise, people that have experience, it always gives you somebody to bounce ideas off of, because this can be really challenging work. As my mother would say, this is the kind of work that takes stick-to-itiveness. It does not get accomplished in a day. So with that, we're going to flip through the lessons learned so we can get to the panel. The first thing, and these are in no particular order, but just my thoughts, is to make sure that you have some point of accountability or leadership. Without that, you don't know who's on first. You don't have somebody that's going to call the group together, track the information, initiate the dialogue. So it's really important that you figure out where that is. In our community, it happens to be our board, but it doesn't need to be our board. There just needs to be a point of accountability and leadership. The second thing I would say is not to lose sight of the vision. Dr. Flaherty mentioned we've been hit with a pandemic, hit with an epidemic, hit with a workforce shortage. You know, each day there are different challenges facing all of us, and you have to like weed through that and keep your eye on the prize. Don't lose sight of the vision. And for us, that vision has always been about the people that we're here to serve, and what they need and how we can be of help. And when money is tight, time is tight, patience can wear thin. And so when you circle the wagons and have discussions, and you make sure that the discussion is always centered on the people that we're there to serve, it calms the waters and it anchors you. The third thing I'd say is that homework matters. You know, it should come as no surprise to any of you that it's always a balance of the testimonials and the personal heartstring stories, but you have to balance that with the science that is out there, because when you do that, then it becomes really hard to argue with what you're doing. So we always, you know, here I am, I always talk about homework like I'm still in school, but we constantly tell people, do your homework. Find out what the facts are, find out what the science says that we should be doing, and let that be our guide. And I want you to understand that within that, that includes us really trying to follow the evidence-based and evidence-informed practices, and that addressing the issue of trauma is weaved through all of that, as well as the issue of trying to address the issue of cultural competence. In our community, when we think about cultural competence, we think of it as how can we create a community of belonging? And Zach, who you're going to hear from later, although we don't have time to go through all that, and it's been mentioned in some of the other webinars, we leads our local delegation in our community that we've had for about 3 years to kind of help us make sure we are reaching out to all points of our community and trying to engage them and have them belong and be relevant in all of the planning and execution of everything that we're doing. Next slide, please. Joanna, thank you very much for the wonderful job you did to talk about, some of the measurement. What I would say is no matter what you do, just find ways that you're measuring things and make sure that you're measuring them from different perspectives. So we collect data from every system in our community that we can get it from, child welfare, the jail, juvenile court, the hospital, so on and so forth, so that it helps us get a composite picture of what's happening within that framework, within the boundaries of our county. And we take that information and we share it with a leadership group. So we have a ROSC leadership committee that's been in place for 10 years. That leadership committee is made up of individuals in recovery, individuals that work at our treatment agencies, our recovery agencies, law enforcement, so on and so forth, all the different systems in our community, because this is about trying to build recovery across our whole community. And so they are overseeing the data and overseeing then the results of what is or is not happening to determine what we need to do next. The more you mobilize your recovery community and include them in everything that you do, the more relevant and the more expedient change will occur. And I can't reinforce that enough. We try and have the voice of lived experience involved in all of our decision making. We don't contract with agencies that don't hire peer support. We want them involved in every committee. The idea is that we don't want to develop things for them or evaluate things about them. We want to develop with them, evaluate with them, grow with them. And again, it's part of that concept of belonging. We don't build it and then ask about it. We ask them in. They are a part of the design, the implementation, and the evaluation of everything that we do. I want to talk a little bit about how change is not linear. And what I mean by that is, we like to think from A to B to C to D, like, well, if we were really going to do this, the first thing we would do is educate the community. The next thing that we would be a PR campaign. And then maybe we'd think about building service X or Y, like in a very linear fashion. But what happens in public entities and in nonprofit organizations that are dependent on securing funds, where you are in the step might not line up with where the resources are. So what we have found to be very effective for us is that we're consistently inventorying what we think our top priorities are, what our big needs are in our community. And then when an opportunity becomes available for a grant or some other resource, if those funds match a priority that we have, we go forward. We don't wait and say, well, we wanted to do this first. We try and capitalize on every opportunity that's out there as long as it matches what our priorities are. And one of the things that's also very helpful with is it helps us determine not what we don't want to go after. So, you know, you all are on listservs, I'm sure, and you see RFPs come across your desk daily. You know, it helps you find out, well, no, I don't need to go after this one, but yes, I need to go after this one. So it kind of keeps you on task. Thank you, Zach. Go ahead. I would say that when there are barriers, be respectful, but be persistent. And what I mean by that is kind of back to that linear thinking. You would have thought that withdrawal management, for example, would have been one of the first things that we would have wanted to get in place in our community. And indeed it was. In 2013, we went to the hospital, knocked on their door, said, we need your help with withdrawal management. Got turned away, went back in 14, got turned away, went back in 15, got turned away, back in 16, got turned away. Finally, we have withdrawal management at our hospital. They're doing our mom's program. They're doing induction from the emergency room. But it was about inviting them to the table. They watched what other people were doing in the community, really began to understand how important that service was to the continuum in our community. And then they made a decision to step forward in a very big way. And it was about continuing to show them the data, continuing to do our homework, continuing to say, look, you know, I'm not in charge of the hospital. I can't tell you what to do. I have to respect that it's your decision right now not to move forward, but it's not going to stop me from coming back and asking you again. So we have that issue with other systems in our community, and we just keep showing respect for the position that they hold and keep showing them the science for them to hopefully move forward with the decisions that we really want them to move towards. I would say that the concept that there is a role for everyone. Everyone in our community is scared to death of me because they know if they're in a room with me, they're going to walk out with something to do. It doesn't matter if you're from a business, from a church, from an agency, from a recreational department, from a service organization, from a restaurant. It doesn't matter. When you draw your framework around where you want to do your ROSC, it means that everybody in that framework has a role to play, because the ROSC is built for individuals who are struggling. And the concept is that we're going to take care of those individuals. And that means where they work, where they play, where they recreate, where they get their treatment. It doesn't matter. We want to be supportive of them wherever they are. And so there's something for everyone. And then one of the things that I consistently mention when I do things like this is I talk about the celebration of moments and milestones. I think too often we keep talking about the number of deaths and overdose. And I really believe that, you know, there's a mortality rate to every disease. And we have to make sure that our workers, because we have such a shortage in our workforce, that our workers and our families understand that that's not the measurement that they will look back on. We want those workers to know every moment and every milestone that they helped an individual achieve. The individuals that are left behind, the moms, the dads, the brothers, the sisters, the children, will remember, I had this Christmas with the person that I love, or I saw them get a job, or they celebrated this birthday with me. And we want them to feel good and understand that those moments and milestones are very important, provide peace and comfort. And the fact that someone succumbed to the disease and died is not necessarily a reflection of a failure on them as the worker. So we want to make sure that we're consistently reinforcing what they are giving, because every moment and milestone they give someone is a gift. So overall, what I would say is, what we're trying to build in our little square is that you meet people where they are, and you make every encounter, no matter where it is, an opportunity for recovery. And so what really has emerged in our community is kind of a different kind of continuum. You can go ahead and advance that, Zach. So the first column here is like, I think what we traditionally think of when we think of, gee, we really need to build a comprehensive set of services for individuals that struggle with mental health or addiction. We need the medication-assisted treatment. We need drug courts. We need mobile response. We need peer support. And all of that is true, and true. And we have worked on building all of those things, including the prevention, including the early intervention, those things that you would traditionally get when you walk into the door of a treatment organization. You have to have all of those comprehensive set of services. But if you think of it like a three-legged stool, we think that there are two other huge components, two other legs to that stool. The second one is about really having a voice in your community for the recovery community, as loud and strong as it can be. And so, it's those recovery support services that are outside of your treatment agency. It's the individuals in recovery being a beacon of hope and a place for other people in recovery. And that's what Focus has been for us, and they're going to talk later. But, they manage our recovery housing. They have recovery guides, battle buddies. We have a recovery center for youth and so on. But the fundamental thing is it's a mobilization of people in recovery reaching out to others in recovery. And then finally, we've had a whole new set of services that have emerged out of outreach and engagement. Because what we learned, and many of you may have heard me talk about the 3 stories of the house framework, is that our systems have been designed for people to walk into the front door to receive services. And that's great for people that are able to get to the front door. But some of the people that need us the most aren't ready, willing, or able to come to the front door. So the onus of responsibility is on us to reach out to them. And so we have a whole slew of services that have emerged in that category. Our Safe Works is a lot of our harm reduction work, and our syringe access falls in that. Our letting individuals advance with dignity is, which is our lead program, is kind of what you might know as good old-fashioned street outreach. We have a quick response team. In our community, we have a program called Welcome to a New Life, which is adult mentoring. So it's really, what I want you to hear. It's, what the programs might be and the services might be in whatever framework, whatever boundaries you're putting that around, they might be different. But the 3-legged stool is just don't focus on what's happening inside an agency, but make sure you're focusing on mobilizing your recovery community, and make sure you're focusing on trying to reach out to those who can't come to you. So with that, what I'm going to do is turn it over to Zach, who's going to facilitate a panel. And what we did is we identified a key individual under each piece of that 3-legged stool. Jenny Williams, who is really going to talk at the agency level, all of those primary treatment, prevention, and early intervention services. Brooke, who's here from the Recovery Center, and then Christina, who's within the agency, but really focused on the outreach and engagement and works most closely with the outreach and engagement efforts of all the other organizations in our community. So with that, I'll turn it over to you, Zach. Thank you.
Great. Thank you very much, Precia. We're looking forward to this panel discussion with everyone. And again, thank you for being here with us this afternoon. You know, we have been very blessed in this community to be able to have a lot of collaborative efforts, as you have heard today, but also have you heard in other webinars with those coalitions. And the folks that are going to talk today have had an engagement, significant engagement in that work. I'm going to pose a question to the panel, and panelists, as I direct the question to you, if you want to talk a little bit more about the work you're doing as far as who you are and your role you play in that agency, that would be fantastic, so they can become a little familiar with what you do. But really, the first question we want to get to really is, what is it like for you to be in this ROSC framework, in this community that has a ROSC, this work that's happening? What is it like to design your services and programs in a collaborative effort and not just focusing with inside your agency or your organization? Jenny, we'll start with you and pose that question to you.
Thanks, Zach. I think that one of the most significant differences is that you have to have a shift in the lens through which you view the work that your specific agency or organization does. I think that you have to come to the table with a greater level of transparency. I often joke with people that, you know, I'm old and I've been in behavioral health care a long time. And one of the first executive directors I worked with kind of set the stage that it was a competitive landscape. He used to use the expression, you can't copyright an idea. So there was kind of this us against everybody else type of mentality. And I think in ROSC, you come to the table with the lens of doing work that is for the greater good of the entire community, and not only the clients that you may serve at your specific organization, but those in need across all of the service providers. And so I think for us, it is that ability to take the time, develop the relationships, bring transparency to problem solve collaboratively and cooperatively, and to kind of focus on the needs of everybody.
Jenny, there's one thing you said I want to ask you to clarify or talk a little bit more about, and you talked about, you know, changing the lens. What little golden nugget do you have, perhaps, as you come into your organization, to share that, to kind of shift that lens? Because it's one thing to come prepared with all of the knowledge and understanding of ROSC, but what maybe was it that kind of sparked that change in the lens within your own organization, a Family Resource Center?
I think it was the ability to see forward movement, to have more services in the community, to hear perspectives of not only the providers and the team members and other organizations, but also the recovery community. I think when we operate with looking at everything through kind of the figuratively kind of four walls of our particular organization, whatever your mission has to be, you can get very kind of entrenched in that tunnel vision. And I think whether it's attending the ROSC leadership meeting or whatever subcommittee it may be, but the ability to hear those different perspectives is a game changer, because sometimes when we're only thinking about our shop, it can, you know, not be even part of the conversation or anything we consider when we're developing programming. And when you come to the table with everybody, it's just a much grander view to get things accomplished.
Yeah. Thank you for that. And speaking of the bigger table, Brooke, you're coming to us from the Recovery and Wellness Community organization. Same question for you. You are a peer-driven organization, but also engage in their bigger landscape. What is it like for your organization to develop your programs and practices collaboratively across the system?
I absolutely love that we are brought to the table in our community. I had experiences before I got the opportunity to work in Hancock County, where I worked at an agency where collaboration wasn't a high priority. And so when I came to Hancock County, I was like, what is all this? I'm like, multiple agencies at a table, people are talking, they're problem solving. And so I can't tell you how like to watch that first for myself and to like get kind of out of that mindset. I think Jenny pointed out where it's like you were seeing something so long and then to see this different shift, how it really does internally shift your mindset too, just to see how it works. And it feels really good because I feel like for the recovery community, that increases our sense of belonging. As people work on recovery consistently and they're really pushing efforts forward, they want that sense of belonging, the shame that sometimes comes or guilt that you feel around your journey at times. And it's not to be judged when you bring yourself to the table this way and you get to say, like, I had this experience. It really like brings that collaborative efforts. And another thing I just want to hit on is like it's really fun and energizing. Like when we come to a meeting to talk with other agencies, like for example, Christina and Jenny, like I know them. Like I get to talk to them, say hi, how's it going? We get to have like real in-depth conversations before we get into like the meat and potatoes of our meeting to problem solve. And I think that relationship component is so huge because it builds this internal trust. And when trust is there, you feel more safe. And so you get that voice and it can feel louder at times and more empowering.
Yeah, I think, we certainly have those formal meetings when we get together to whether it's the ROSC Leadership Committee or even the community partnership that focuses on prevention. But what you're speaking to is that allows those relationships to develop, that you could go out and have a cup of coffee with Jenny or Christina and still be talking about developing stuff, but it's an organic process and it allows those brainstorming circumstances to happen so that you can continue to build upon the structure and the framework. So I appreciate you bringing that out because that's really important to know that, the building of the trust and the relationships and also the programming doesn't just have to happen within the four walls of a boardroom or a conference room. Brooke, there's one other thing, and you may talk about this a little bit later when we talk about challenges, but I seem to recall when peers would come to meetings, there was a lot of trepidation and a lot of, well, I don't know if I should be speaking up because I've never been in spaces like this before, nor have I ever been asked to be in spaces like this. What nugget of help or a highlight could you provide to the viewers here today? How do you encourage people that are in recovery to come to the table and be willing to do that with their voice?
I think extending the invite is pretty huge because a lot of peers don't understand, like just because you don't have a bachelor's degree, that you don't have education. Their lived experience is that education. And I think acknowledging that to someone, like you have this knowledge that I don't have, and I'd love to hear more from you. So I think just that invite sometimes is really helpful. Or I know if someone's in a leadership role, just reiterating their own experiences that they're seeing. Because I know when I talk with my own team, I say like, okay, I went to this meeting, this was asked of us. So I can get that feedback and reiterate, like we're being invited, they want to hear. And so I think that's really important too.
Yeah. Thank you, Brooke, for that. Christina, you work within the organization as Jenny with Family Resource Center, but you are someone who is really meeting folks sometimes in the deepest throes of their addiction or where they are. You go to where they are. From your chair that you sit in, and what is it like for you to plan your outreach work within the context of ROSC, and how do you do that collaboratively with perhaps, as Jenny was talking about, some of the administration folks that maybe don't quite have the same perspective yet, or still need to have that kind of drive to listen and understand what's going on?
Thank you for that question, because I think with the development of ROSC, it has almost really helped to set us up to be successful, to be out in the community, because when we develop programming, with ROSC, we're doing it very deliberately and we're trying to meet a need. And because we're bringing everybody in to discuss it, we're also bringing in, we're assessing what everybody's capacity is, what their roles are going to be, what the needs are, and utilizing their expertise. And which we need that information when we set goals as a community. And so it almost feels like when we are out in the community and applying these services, it almost feels like they're ready for us because of all of the preparation that went into the development of it. And it kind of feels like we're a puzzle piece that fits in perfectly. And I think that that's also a testament to the other community agencies involved who agree and who also try to leverage these services and make referrals. So I feel like our success is because of our continuous communication and collaboration, if that makes sense.
Yeah, absolutely. I want to kind of the second question we have, and Christina, I'll shoot it over to you. With that community involvement, has it modified how when you originally thought about implementing these programs, and even the evaluation components? We have Brandeis that's helping us with that evaluation piece, but you on yourself, how are you evaluating with that community involvement what you need to do and modify and change for those programs?
So I think, once again, because of our continuum of care, there's like this community-driven accountability to our outcomes. And it feels like when I'm looking at our outcomes, I'm able to do it from a very objective perspective, because I know all of the external factors that are like impacting our outcomes. And that really helps us, because our goals for changing things, if we're looking at it subjectively, we could be missing things. We could be missing the gaps. And I would say, because of our continuum of care, I'm able to have that perspective, which helps move things along, and we can improve things a little bit more efficiently.
Yeah, thank you. Jenny, at the organizational level, looking across, prevention, treatment, and recovery supports, how has community involvement influenced evaluation processes at that entire the enterprise level for a family resource center?
I think that one of the key things I notice is that you get a much broader and deeper range of feedback and input, and you get that much sooner. I think, to Brooke's point, the relationships that develop and that camaraderie, that trust, if one of the other, systems in the community is experiencing a challenge with maybe a particular service, maybe it could even be a team member that something is not being executed the way it should be. It is not uncommon for any of us to pick up the phone and be like, hey, Brooke, could we chat about X, Y, or Z? And then figure out what changes or continual improvement measures need to be implemented to take that feedback and make us better, make us stronger, make our services more effective for the community. So I think that would be the biggest thing I notice, is that we get that feedback much sooner, excuse me, and it's much more meaningful.
Yeah. Brooke, I saw you shaking your head a lot. Is there, you agree with Jenny on that? Anything you'd like to add for your organization?
Yeah, no, I definitely want to mimic what Jenny was saying around, like, when I think about community involvement, and as you said, we're looking at like how we're getting that feedback. That's huge for us with other organizations. And I think at Focus, we can take it to another level of receiving the participant feedback continually, because as a recovery community organization, every one of us that works here is in recovery ourselves around substance use, mental health, or trauma struggles, but also individuals coming through our door are also working on their own recovery journey, either through our youth center, our housing, our adult center. So we're able to take their feedback as well and put that towards how we're doing our programming or identifying some gaps or needs. And all that is able to be shared then, because it's not just coming from strictly organizations, it's coming from people with the firsthand lived experience around it.
And I know we've all kind of spoken to this, or you have all spoken to this in your responses already, but really the heart of today's webinar is really inclusion of that voice of lived experience. And Brooke, I'll toss it back to you again. How has the inclusion of that voice really influenced or shaped the work in your organization? And I know you've talked about that in a way, but maybe there's something very poignant that sticks out in your mind that maybe kind of shifted the spirit of your organization, or kind of like the motivation. How has knowing that their voices are being included really accelerated the work you do at Focus?
So obviously it appears in all our work because we have everyone lived experience, and that's what's really great about it. And when I think about the shift, I really look at how we have more diversity in Focus. Like, we don't have individuals have solely that they identify mental health recovery. We have individuals that say, I only have substance use disorder recovery. And so trying to build a agency where we have different cultural diversities is really shaped on how we can make decisions and how we look at more of our programming. It makes me really think about like the community outreach team we have, for example, that we had people coming through our doors saying like, I wish you guys were open more, or I can't get to you. We had continual phone calls around like the need of transportation, how they can't get to Focus. And so having the opportunity to have a grant, because we were able to hear that feedback from the community, that we were able to take services to people to get them peer recovery supports. And so I think that really, again, shaped the voice of using lived experience, of identifying that gap that we have within our community at times around transportation. And also, I just want to hit that like peer support is like the heart of what we're doing, because we know that it's an evidence-based program, that it improves quality for individuals, the outcomes of their lives are much better for them, that they're saying as we walk alongside them. And to be able to increase that sense of belonging for us has really shaped how we do things. We've had people, for example, that say like, I wasn't feeling as belonged because I wasn't seeing a course here on how we had individuals struggling with their mental health and a coping skill on that. So we were able to find someone within our staff that's like, oh no, I have lived experience around this. Let me facilitate a support group on this. And so again, we're able to bring that into our work. And that's really what drives what we're doing here.
Yeah, lots of empowerment happening there. Christina, anything that jumps out to you in relationship to this question?
Yeah, so my case managers on my outreach and engagement team have lived experience. And just like Brooke said, we know that having people with lived experience working with in the community and with this population, we're increasing the likelihood that that person could enter into recovery. And I think another piece that makes lived experience so great is that it really it fosters a safe and trusting environment for individuals, and it can normalize experiences for people. And I think when experiences can be related to, it will also reduce that feeling of shame, which we know plays such a significant role in addiction. And so my team really feeds into that and really tries to relate to them on that level. And they go at the individual's pace. And we've really seen engagement rates rise because of us utilizing that lived experience.
Yeah, thank you. Jenny, anything else you'd like to add from your organization's perspective as far as, the inclusion of voice and how that has influenced the work of FRC in the community?
I think Christina hit on how it's influenced the work of FRC in the community, but I guess I would kind of shift that question a little bit to talk a little bit how it has influenced the operations of the organization, because it is a unique addition to our workforce, and our understanding of what those unique needs are has evolved over time. Because I think one of the things when you have a very significant portion of your workforce having their own lived experience, we know the work that all of our providers do in behavioral health, it is hard work. And we have to make sure that the mental health needs and the long term recovery is sustained for our peers. And so we as an organization have had to look at how we operate to support that. So for example, we had some of our peer supports who said, listen, I started this job, I like this job, I want to help other people, but your policy of not having the availability of using any PTO for 90 days, which is pretty standard at a lot of, companies, employers, they said, I can't get to my counseling appointment. I can't get to my, MAT appointments or whatever it may be. So we looked at that and we made a change in our organizational policy to allow people to be able to access their earned PTO within their first 30 days so that we're not ever putting their long-term recovery in jeopardy. One of the other examples is that, there was feedback about, boy, where we're meeting people, talking to people, trying to get them engaged in treatment, us showing up in, kind of business attire may not make those we're doing outreach feel the most comfortable. So we shifted to a dress for your day dress code policy. And so I think part of it too is your organization has to adapt internally as well as adjusting about the services you're delivering outward.
Yeah, I really appreciate you kind of changing the question to the internal operations. It kind of leads the question I have about the challenges you've experienced. I think taking some of that time for self-reflection on internal policies is really powerful. And I think that the idea of doing a ROSC is not just for the community, but you have to take care of that organization that's going to serve those folks as well. Jenny, I want to ask you in that same kind of vein, like what has been some of those other challenges or big challenges in order to sustain the framework of ROSC within your organization?
I think one of the significant shifts would be a greater understanding about what those supervision needs are for those with lived experience and how those supervisors can effectively support them. And it is something that is a fine balance. And I'm sure Brooke and Christina can talk a little bit about that more. But I think that even from the standpoint of, for example, our human resources team and the recruiters understanding more about what is long-term recovery, how do you get insight about somebody and their recovery journey to be a good fit for one of our open positions through a phone screen or moving somebody forward. So you have to also make an investment at the organizational level about educating everybody. Because I think just the way those that might be filling these positions might have experience with kind of the shame, the stigma that they experience out in the community. We want to ensure and minimize that that's not happening internally at the organizational level, because we want our peers to be as important part of the treatment team as the psychiatrist, the nurse practitioner, the counselor, the case managers. We want everybody on that equal footing. And that takes an investment of time and energy in our education process internally.
Brooke, how about at Focus? You know, what I saw you shaking your head as well for the supervision challenges, but what are the challenges that you've experienced in order to sustain the ROSC framework?
I think Jenny was like completely on the right track around the supervision component, and just kind of like the lack of clarity of what peer support is, like what their lane is, what they do. I don't think there's a full understanding at times, and especially individuals who are newer in recovery working towards peer support. And if they themselves haven't gone through certification yet to get their peer support certificate, they're still learning skills such as professionalism, like what is my job? And I think it's important that you do have a supervisor that is able to have gone through the supervisor peer support training, along with having their own lived experience of understanding peers. Because I could say it really, like my supervisions were much different when I meet with someone as first peer support versus in a prior role when I worked in community corrections. So it really is a different dynamic. And I think being thoughtful and conscious about that, and ensuring that those recovery check-ins are happening, because those are really important. We want peers to stay in this field and to build themselves up. And peer support is usually that introductory role into this. And it's awesome, because I can't tell you enough, when I do an interview with someone, my first question is, tell me about your recovery. I leave it very general for them to share whatever they feel comfortable with. And after someone shares that, I thank them, and I'm like, that is so awesome. Like that you have this education behind you, your lived experience, and I validate them for that. And sometimes the reactions are like taken back, like, what? And I'm like, no, this is so awesome of you to be able to empower yourself by sharing what you have and knowing like we value that about you. And I think that's just that educational component can go a really far way to communities around what the peer support role is and what their lane is meant to do, because it can be very effective, as we know and have seen within ROSC, when we incorporate individuals with lived experience.
Christina, what are those challenges look like from your chair?
It's been it's kind of, at least from like an HR standpoint, to kind of go off of what Jenny said of, you know, some of the positions that I have open, you know, I'd look at a resume and I'm like, they don't have a criminal record. I don't want this person. I need a criminal, you know what I mean? Like I want the people with lived experience to come in, and it's probably just a really big, I mean, that's a really big shift for a lot of organizations, that you know, those are the individuals that we want, because those are the ones that we know have huge impact on people's lives. I would say another thing that we have implemented is the celebrating of recovery milestones in people's lives that work here. And it's very general, like it's whatever that individual defines as recovery, and they don't even have to be specific, but we try to keep track of those dates and celebrate them in ways that they want to be celebrated. You know, they may not want like a big agency email, but maybe just something from their supervisor. So that is something that we've implemented in the past year. And just, I think, on a broader sense, that with coming from a community mental health agency, you know, originally, like Precia was saying, how people come into our services is through the door, DA or a diagnostic assessment, and they have a wide array of services that are available. And, you know, bringing the door to the individuals in the community. And that has been adjustment, and because it really does shift us from that traditional pathway to services. And being able to adapt to that, I think is one of the biggest pieces that we need to sustain ROSC within your agency.
Brooke, go ahead.
Oh, yeah. I was thinking too, as you were talking about this question, and it made me think of the S word, and not that S word, but for us, stigma. I think that is also a challenge that can be faced quite a bit. And I know in our community, like that's something that's put in the forefront of meetings around like how do we address this? What's things that we can put out? So I just want to highlight that I think that's something really important that needs to be in the forefront of people's mind, is what stigmas in our community and what efforts can be put towards that.
Yeah, I've heard in our conversation, you know, the ideas of when we talk about sustaining ROSC, you know, certainly modifying policies, internal policies, the importance of education, not only for the community that works with your organization, but also internally, addressing stigma, and certainly the celebrations and achievements and those milestones. When you think about your vision board you have for ROSC, and I'll open this up for anyone that would like to answer, kind of what are those components that you see that still need to be actualized or, you know, become the reality as we continue to move forward the ROSC framework in our community? So what are those vision pieces you still have that you're working towards, that you want to see come to fruition at some point?
I think, you know, just more people coming to the table. You know, we know that we have a lot of community partnerships, and that's why ROSC has been so successful. But we know about some of those whose voices are not as included. And like Precia had said, you know, we just keep asking, and we just be persistent, but we be kind and respectful. And so I think one of my visions is, you know, bringing those voices that are so important to the table and just continuing to try and include those individuals.
Thank you. Any other thoughts, Jenny or Brooke? One of the things that, you know, I think this speaks to Christina, what you were saying about bringing more people to the table. You know, ATTC has, the board, the mental health board has developed, you know, some really strong relationships with elected officials and people that make policy at a government level. Has this influenced, or has this encouraged you to build upon those relationships? Or let me ask it this way: have you seen in your work with ATTC and other organizations that relationship with the elected officials in advancing the ROSC framework?
Yeah, so we work closely with, you know, city administration and update them on what we're seeing from, you know, my outreach and engagement team. And we keep that line of communication open. And I think, you know, something else that I do is I try to keep up to date on what's happening within our community. You know, I watch every city council meeting, you know, I try very hard to stay up to date. And I think being informed and also including them in the conversation, and, you know, inviting them to the meetings. And I think that those pieces we really need their input. You know, it's hard to do things without, you know, having you know, that city administration voice in the room. So yes, at least from, you know, an outreach and engagement standpoint, just trying to stay informed and including them in on our meetings with updates.
If you don't mind, panelists, I'd like to bring Precia back on the screen, because I know that in her chair and her role, she's done quite a bit of work with our elected officials, not only at our local level, but all the way to our state and federal level. So Precia, what insight do you have related to working with elected officials to advance ROSC would you have to share?
Well, I thought I'd share an example because I thought people might be thinking, Oh my gosh, it's oh so rosy. How can it be oh so rosy there? I thought maybe I'd share a pain point. So in 2015, we tried to do recovery housing. Well, we tried to do recovery housing before we, again, kind of back to that matching a need with a resource. We had funds that were available. So we're like, we'll go forward with recovery housing. We really hadn't done a lot of communication throughout our community on recovery and what it meant and so on and so forth. We ended up with a community, a neighborhood that actually formed an LLC, Save Our Neighborhoods, to prevent us from doing recovery housing, so on and so forth. But in relationship to elected officials, what I wanted to bring your attention to is that prior to that, we had not been meeting with the mayor. You know, we're a county entity. I've always met with the county commissioners every quarter, had never met with the mayor on any kind of ongoing basis. Well, we learned really quick that those recovery homes happen in a city, and you have to work with the mayor. And so ever since that time, what got put in place is just like clockwork. We meet with the mayor every 6 months just to touch base. And now, as the settlement funds are coming into our community from all the pharmaceutical companies, the mayor has reached out to us to get our advice on how those funds should be spent. It just kind of came full circle. The other big group that we learned the hard way, you know, we had these horrible headlines in the newspaper when that was going on. You know, our board tries to do a home for addicts. You know, just not the person first language that we wanted, anything like that. We didn't have a relationship with our local newspaper. We hadn't established a relationship with our, you know, editor or anything like that. And ever since that time, boy, we know people at the newspaper on a first name basis. They know us, and it has changed the language in which the written communication in our community comes out to the general community. So I would say that, you know, it's one of those things we learned over time. There, as I said, there's like no part of the community that you can leave out. And that really includes our elected officials.
Yeah, Precia, I
Thank you
appreciate.
for letting me do that.
Yeah, and if you could stay on, because there was a question in the Q&A earlier on, someone very early on in the webinar asked, how is all of this funded? And
Oh.
I know that it was kind of spoken about, especially in Joanna's presentation, about the different grants we work on, but how do we do this in Hancock County?
So yes, I will have to say this has been a very expensive endeavor, and we had 0 new funds to start. And so what we did is, you know, the very first grant that we got was a small local grant with a portion of our foundation, this Handbags That Helps thing. And it was about trying to teach our community what trauma means, the impact that it has, and how we could introduce our community on the importance of becoming trauma informed. And when we presented to them, we told them, you know, this will leave a legacy if you do this. Well, one of the things that Dr. Flaherty shared with us is get the first grant and the second grant will come. Get the second one and the third one will come. And he was right, because when we did that, then when we wrote like our first federal grant with BJA, which I will say that BJA grants have been very generous to us, we were able to say, okay, we've built this foundation related to trauma. We want to go into the criminal justice system, you know? And so what I would say is, every new thing we've done, we've had to go out and find funding to do it. The relationship that has been established with Brandeis University has been absolutely critical in that, because not only do we have their findings from other work, but we have their assistance in helping us with the next proposal, because they are added in as the evaluators. So they get business out of it, and we get funding, and we get that quality improvement piece of our evaluation. So in short, I would say if you're close to a university or know of a university, Brandeis is not in our town, but in this day and age of Zoom, it doesn't matter. You can have a relationship with somebody anywhere in the country. I would say nurture a relationship with a research institute that's interested in this cause. Don't be afraid to write the first grant. Once you get the first one, the next one will be easier, and you can continue to build. And early on, I mentioned the need to follow the science and do the homework. People want to invest in things that they know are going to have an impact. And you can, as long as that is your base, then you can add, like, well, this is something unique we want to try with the funds, so that we can contribute to trying to advance the science.
Thank you. We have just a few minutes left. I just would like to ask our panelists, Jenny, I'll start with you. Is there any one last piece of advice or motivation that you'd like to leave our audience with today?
I think it would be to trust the process, and that bringing everybody to the table and looking at the greater good of the community reaps immeasurable awards or rewards. And those relationships, whether it's coming together to, as Precia said, write and plan and dream that first grant, or figuring out how our outreach and engagement is strengthened, whatever it may be, there's just a lot of power that comes through the entire ROSC process.
Thank you, Jenny. Christina, last words of wisdom.
I think the removal of working in silos, and very similar to what we do internally. If we staff cases, we do it, it's like interdisciplinary work. And that's kind of what this is when we plan, and we're bringing in all the people that it affects. And I think that if you can do that, you'll move. You'll be able to make headway if you start having those conversations and bringing in the correct people.
Thank you, Christina. Brooke?
From my chair, I think one of the biggest lessons I have learned since I started working in Hancock County is really to be open-minded to ideas, because I can't tell you, sometimes I hear something and I'm like, oh man, all the extra work this is going to cause, or I keep thinking of all the reasons this will not work. But again, like, yes, your support systems are there within, you built this within ROSC, and it's like, pull them in. Like, I cannot tell you the wealth of knowledge that everyone on this call has, that like, that's where I learned from, because you're not alone. But I can just tell myself, like, it's going to be okay. And something that doesn't feel right all the time, or to sit back and really just evaluate it a little bit more, because usually it's always coming from a good place with someone. And that's why it's really important just to have that open mind. And especially, just one last plug, that lived experience is so important in our work. So really value individuals when they share that piece of them, because it is a piece of them that they are sharing. And so I think this was really great. So thank you.
I appreciate that, Brooke, very much. Thanks. Precia, any last words?
The only thing I would say is that the genuineness with which you approach an individual is more meaningful to them than anything. And the more we build that across the community, a genuine desire that they can feel and see that we want to help, that's how we're going to build more and more success. And if that is at the heart of all that we build and do, you can't not have a positive impact.
Thank you. Well, again, thank you to our panelists and Precia and Dr. Flaherty and Joanna. Thank you as well for presenting today. You know, these 3 webinars have been tremendous, and we look forward to continuing to share them out in the community. Alyssa, I'll turn it back to you. I see you put some notes in the chat, but anything you need to let the audience know, it's all yours.
Yeah. Thanks so much, Zach and the panelists and everyone for joining us the last 3 sessions. I will reiterate the things that I put in the chat. You will be redirected to that very brief survey. We would greatly, greatly appreciate it if you could fill that out. It does allow us to continue to provide free trainings to you all. So that survey we take very seriously. We look through the responses, and we do our best to give you all such high quality presentations. Certificates of attendance will be sent out via email following today's presentation. Please check your spam and or junk folder. Sometimes our emails do end up there. You should be getting that either tonight or tomorrow. And then I will send out a follow-up email with the recordings. But we do have that landing page link that I put in the chat for you all if you would like to watch session 1 and session 2 and maybe show others today's recording as well. So I will get that recording posted on our website by the end of today. Otherwise, that's all my reminders. I just want to thank you all for joining us. If you joined us for the last 3 sessions, we appreciate you being here. And we look forward to seeing you on future Great Lakes ATTC trainings.
Thank you.
Thank you.